So we are making progress. I think the staff is much more informed than they used to be, and we need to build our best arguments. We also need to be honest brokers about what we can and can't do. I mean, the chest thumping like nursing is the center of the universe doesn't really get us very far, okay? There's a lot of that. Like, we're at Penn, we're the ground. Find out, you know. I actually have the right colors on to save it. I think you, like I say, I introduce myself by my story. I think we lead by our example. And I think we lead by showing what it is we do, understanding where, like with discharge planning, if we really make a difference, you really want to make an argument, what you would do is a study that shows how many people come back in and how many people don't come back in as a result of the plans that we put in place for strong discharge planning and follow-up. And maybe that means that the way we deliver nursing care now is completely wrong. Right? Maybe rather than, I mean, you take care of somebody when they're in the hospital. Once they're in the hospital, you're done, right? Well, does that make any sense? We have a system of delivering care and paying for care that keeps people in these little silos. Guess what? People go across silos. Patient-focused care says you follow them across the silos. But we're not set up to do that. I mean, how often do we engage the Visiting Nurse Association or the Visiting Nurse Service after somebody goes home? You, as a hospital nurse, 0, maybe 0.1. But wouldn't that make sense? If you were, when I was a public health nurse, the most important thing I could do was call back to the hospital, call back to the outpatient clinic, talk to the staff there, and engage them through the entire time that I was seeing someone, because they knew what went on. And I could also give them information about what was going on in the home for their next visit. I did that independently because it was the only thing that made sense. Well, why don't we deliver nursing care that way? But we don't. We know what works, and that's what I started with. We know what works. So in health reform, as a real quick civics lesson, the health legislation, any health legislation that comes out is in the province or in the jurisdiction of specific committees in both the House and in the Senate. In the House and the Senate has an entire committee structure. The House is bigger, it's got more committees, and it's like 30-something. They keep creating new ones, and I think the Senate has around 20. Right? But they have a whole variety of committees, and only certain ones of them have jurisdiction over health care. And in the current debate over health care, in the House we have 3 principal committees that took on legislation. They decided what they were going to do is write one big fat bill called H.R. 3200, which is House of Representatives, which is how every bill in the House starts out with an H.R. 3200. That was their bill. And the 3 committees, the senior staff, that is the senior leadership on the 3 committees, got together and wrote the bill. And that is the House Ways and Means Committee, because they have jurisdiction over Medicare and Medicaid, parts of Medicaid, mostly Medicare. Energy and Commerce, what? They have jurisdiction over FDA, Public Health Service, and Medicaid. And then Education and Labor, because health professions education is in there. So those are the 3 committees. Now their process was they got together and they wrote a bill. And it has all 3 parts in it, one big fat omnibus bill. Now each committee, the way that legislation works, each committee takes the bill that is in their jurisdiction, they argue it out, and that's called markup. So they take a piece of legislation, they mark it up, that is, they debate it, and then their whole committee votes on it. And when they get done with it, it then goes to the House floor, and it's voted on there. So we wrote one big fat bill up here, right? Well, Ed and Labor had jurisdiction over part of it, Ways and Means Committee had part, and Energy and Commerce. So they took the bill, split it up into their 3 parts. This was all this summer. And each one of them did what committees normally do. Argue it out, mark it up, do all of that. So they all reported out, and their committees all voted on that. What they've been doing over the recess is they've been putting Humpty Dumpty back together. So now they're down here and they're stitching their bill together. And that is what's going to go to the entire House of Representatives to be voted on. They're in that process right now. The Senate decided not to write one big fat bill. The two committees of jurisdiction is Health, Education, Labor, Pensions, HELP. So and that was the chair of that was the late Senator Kennedy. As he was unable to go through most of the markup process, Chris Dodd, who was second in command there from Connecticut, Senator Dodd led that debate. Right, since Senator Kennedy passed away, the new chair, the established chair of that committee is Senator Tom Harkin from Iowa. Huge nursing fan, huge, very liberal, very much, he'd have single payer if he could. From Iowa, where Senator Grassley completely fenced over, very interesting. He was on C-SPAN yesterday. I know, I watch C-SPAN on Sunday. What could I say? I actually made sure I didn't miss it. That's one committee, and the Senate Finance Committee is the second committee that has jurisdiction. The Finance Committee has jurisdiction over Medicare and Medicaid. That is split up in the House. It's all in one committee here. Education, Labor, and Pensions has all the rest of it. So health professions, education, FDA, public health service, all the rest of it is in theirs. So they have, the Health, Education, Labor, and Pensions Committee finished up their work before the recess. And their bill is sitting there. Right. Finance was in breathing some rarefied air and thought they were actually going to be able to, if they waited and worked hard enough, they would actually get a bill that would come out that they would be able to get part of the Republican leadership in the Senate, on the Senate Finance Committee to come on board. So they took a lot of time working out a bill and then ultimately just lost all the Republicans who were working on it. Now that is the bill that everybody was talking about last week. Finally, they have coughed out their part of it. Now you hear this stuff called scoring. Every piece of, since the early 1970s legislation that was passed then, every piece of legislation that is offered has to have a price tag. So you got to know what it's going to cost or what it's going to save, whatever it is, whatever that bottom line is. And the process that you go through to get that is by taking it to the Congressional Budget Office, because that's the office that's responsible for doing that for the Congress. The Office of Management and Budget, that Peter Orszag is here, they do that same function, but for the executive branch. So they do that for the president. The Congressional Budget Office does that for the Congress. So any bill, not just health reform, any bill goes to the Congressional Budget Office, and they give it a number. Like how much is it going to cost you or how much is it going to save? And they call that a score. So the Finance Committee finally coughed out their bill, and everyone was talking about its score because it saved money. And some of it's funny money. I mean, they have these time windows, so they have to show what's going to happen in 5 years or 10 years by law. So let's say you put something in over 20 years, it's going to save you money. What's going to cost you money in the first 10? Doesn't matter if it saves you. Nobody cares about what it does 20 years out. You got to fit this narrow little time window. So sometimes things look like they cost money because you got to spend to save. Well, if the time window is only the spending window, you lose money. It's the vote. I mean, it's probably still a good thing, but it doesn't matter. So they've come out with theirs.